I'm presenting the case of
Yeah.
the babies of Mrs. XYZ who were examined on the 11th day of life. Both were female babies. They hail from Kanakpura from Bangalore. They were examined on the 25th of December, and the period of gestation was 35 weeks and 2 days. Presenting complaints, the mother came with complaints of lower abdominal pain along with leak per vaginum and delivered twins by normal vaginal delivery. Both the twins were shifted to NICU in view of low birth weight, and the second baby not having cried at birth. Both the twins were shifted to the mother's side on the 5th day of life.
Yeah. Go ahead.
Antenatal history, mother, age was 25 years, active married life for 11 months. She conceived spontaneously after 2 months of married life, which with no history of contraceptive use. Her current score comes to para 1 living 2. The mother is moderately built and nourished. The case was registered at a government hospital in Kanakpura. First trimester history, pregnancy was diagnosed by urine pregnancy test and was confirmed by ultrasound scan at 1.5 months of amenorrhea. She was told that the scan was normal and was of a single life fetus. She started taking folic acid tablets and was immunized with the first dose of TT. There is no history of excessive vomiting, radiation exposure, fever with rash, drug intake, or increased frequency of micturition or bleed per vaginum. Second trimester, quickening was felt at around the 5th month. Iron calcium tablets were taken regularly and she was immunized with the second dose of TT. Second ultrasound was done at the 6th month and then she was told to have conceived twins and that both the babies were normal. She was also advised to start taking double the dose of supplements. There was no history of increased blood pressure or sugar recording, any history of suggestive of preeclampsia, bleed or leak per vaginum, or increased frequency of micturition. Third trimester, she continued to perceive fetal movements well and continued taking the iron and calcium tablets. There was no history again of suggestive of increased blood pressure or sugar recording or history such as preeclampsia, bleed per vaginum, or increased frequency of micturition. Her weight gain was 15 kgs and the mother had continued work. She was a garment worker and she worked for about 8 hours per day till the end of the 8th month. Natal history,
Okay. We'll stop at this.
she developed lower abdominal pain that was
Prashant,
intermittent, increasing in frequency, intensity, and duration, radiating to
Prashant,
the
can we
back and
stop
inner
at
side of
this?
thighs and associated with leak per vaginum
Prashant,
during
could
the
you
early
please
hours of
stop?
14th December, for which she was rushed to the hospital. And after an initial assessment, she was told to be in labor and was shifted to the labor room.
Yeah, Prashant, can we stop at this, please? Can you hear us, Prashant? Prashant, am I audible?
Yes, sir, you're audible, sir. Prashant, are you able to hear us?
Hello?
Yeah,
Prashant,
can you hear us, Prashant?
Uh,
are you not able to? You need to join the audio.
Okay. Meanwhile, till he comes back, let's uh, introduce the topic to the others who are hearing. Can you all, am I audible to all of you all?
Yes, sir, you're audible, sir.
Okay, so today Prashant has chosen a low birth weight infant, that is a low birth weight neonate. So one of the, as I told you, I think the last session which we moderated was a normal newborn. So typically 3 cases are normally kept for newborn examination for undergraduates. One is the normal newborn. The second group of newborns which are kept is the low birth weight newborn. And the third one is with a newborn with a problem. So it could be birth asphyxia, or it could be jaundice, or it could be some common problem. So these are the three type of cases you're going to get in undergraduation. Okay. And this time, probably you may have a case scenario or you may have the case itself. But definitely one will be a newborn, so that you can be sure of. Okay, now since Prashant has started
Hel-
off with you.
Yes, sir.
Hello,
So
sir.
now he is able to hear, sir.
Okay.
Sorry, sir, I couldn't hear you. Should I start again?
No, 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 no. We heard the presentation. So can you go back to the first slide? No, I thought we'll just break this into
Yes,
the
sir.
antenatal history, then natal and intranatal. We'll just go along with the associated questions which can be asked.
Yes, sir. Yes, sir. Sorry, sir.
Right. Okay.
From here.
Yes, yeah, yeah. As once we know that now, the discussion will be more focused as per the low birth weight infant. Okay.
Yes, sir.
So since we have already covered the normal newborn, so today, because there's a lot of things to discuss about low birth infant, so we'll just focus on low birth infant.
Yes, sir.
Okay. So now, as he said, the period of gestation is 35 weeks, 2 days. Prashant, can you
Yes, sir.
tell us, like, how do we classify newborn? How do we classify newborn?
Uh, in terms of term, preterm,
Okay.
so term will be from 37 completed weeks till 41 weeks, 6 days.
Okay.
And preterm will be anything that is less than 37 completed weeks.
Okay.
In pre- in And we also have post dated, that is after 40 weeks, and post term will be after 42 completed weeks.
Okay.
Under preterm, we again have late preterm, moderate preterm, and early preterm.
Okay.
So less than 28 weeks will be early preterm.
Okay.
28 to 30, uh, 32 weeks will be moderate preterm, and 32 to 37 weeks will be late preterm.
Okay, fine. So I'll just help you a bit. So what we do is the first, as soon as you start with the case scenario itself, so since you have brought the point of gestation, the question at this point of time would be, how do you classify newborn? So whenever you answer a question, it's always good to classify that. I would like to classify the newborn based on gestation, based on weight, and then based on weight and gestation. So these are the three ways
Yes, sir.
to classify newborn. So as Prashant said, based on gestation, he's right. 37 completed weeks will be term.
Yes.
37 completed weeks will be term. Anything below 37 weeks is preterm. And in preterm, we further classify them as less than 28 weeks. Somebody who's less than 28 weeks will fall under extreme preterm. 28 to 32 weeks will be very preterm.
Yes.
And 32 to 34 weeks will be moderate preterm. And 34 to 36, 6 bar 7, even one day is 37 completed weeks. So 34 to 36, 6 bar 7 is the late preterm. Is that clear? So you
Yes.
have to make a note of this, because there's one question which is definitely going to be asked. So based on gestation, this is how we are going to classify. And then you say, based on the weight, I would like to classify you. We know that average Indian newborn will be around, say, 2.8 kgs, but below 2.6, 2.5 kgs, 2,500 grams. Anybody who's below 2,500 grams will be labeled as low birth weight neonate. So today's discussion will be based on this population, low birth weight neonate. And in low birth weight neonate, we further classify them as, if they are less than 1 kg or 1,000 grams, we call them extreme low birth weight. 1 to 1.5, we call them very low birth weight.
Yes.
And then low birth weight above 1.5 to 2.5, they're again low birth weight. Okay, above 2.5, they're said to be normal weight. Fine. So
Yes, sir.
then you would like to classify them based on both gestation and weight. You classify them based on both gestation and weight. So you want to know, for that appropriate for that gestation, is his growth appropriate? Like for example, if he has completed 9 months gestation, we expect him to be above 2.5 kgs. So we use a chart, either the Lubchenko's chart or the Fenton's chart, and when we classify them and we compare it to the population of all low birth weight newborns, if he is below 10th centile for that population, then you would call him as SGA. If for that particular gestation, if he's below 10th centile, we call
Yes.
him as small for gestational age. Between 10th and 90th centile, he's appropriate for gestational age. And if he's above 90th centile, he's large for gestation age. Fine. So
Yes, sir.
that's how you would answer, saying that if somebody asks you how do you classify newborn, you would say I classify them based on gestation, I classify them based on weight, and both gestation and weight. Okay,
Yes,
then you get the question of whether it is small for gestation age is appropriate, or because it's most very important, because at the end when they ask you final diagnosis, it should start with this. So
yes,
what is the gestation, whether he's appropriate, and then whether he's low birth weight, normal or not, you're going to tell. That is the first opening statement of your diagnosis, right?
yes,
Fine. So go ahead with the next slide. Yeah. So next slide, he's very beautifully blot out that the mother came with complaints of lower abdominal pain. She had leak per vagina and delivered twins. Okay, he has already told us almost the natal history. We'll come back to it in a bit. We'll just go to antenatal history. Yeah, antenatal history. So all of us know last time we discussed that the antenatal history we divided into first trimester, second trimester, and third trimester history. First trimester, yes, he has told us about the mother's age. He has told us about married life, non-consanguineous, consanguinity, excellent. He has told us most of the things which is required. And they say mother is spontaneously conceived after 2 months of married life. Fine. Again, here, conceived spontaneously or assisted is more important for twinning,
yes,
because the twin, if it is ovulation induced or in vitro fertilization induced, the chance of twinning is more. More so if the mother's age is more. If the mother's age is more, there's increased FSH, and therefore there's more chances of twinning. Or if there is a family history of twins. So we can
yes,
ask if there's a family history of twins, mother's age being like more than 35, or if there's assisted IVF or ovulation induction drugs were given, then yes. Okay, fine. So next, coming to the first trimester proper.
yes, sir.
First trimester proper. So here, in a low birth weight infant, I would like to know what has caused his low birth weight. Why is he low birth weight? For which I may find answers in my first trimester, or I may find answers in the second trimester, or I may find answers probably in the third trimester also. So we know that by getting few questions, we can come to the etiology, why this baby is small. Correct. That's why
Yes,
it
sir.
is very important, and definitely questions will be asked on what are the causes of low birth weight infants. Okay, fine.
Yes,
So you have told in the first trimester. So in the first trimester, preferably we would like you to avoid pregnancy being confirmed by UPT. That's okay for OBG, but in pediatrics, we don't expect you to tell that pregnancy was confirmed by UPT.
yes,
All that is not required. So what you can just say that whether she was booked or booked,
yes, sir.
and then
That I had a confusion because book with the definition is for at least 4 visits taken iron and calcium tablets, and
yeah.
because she told that she hasn't had frequent visits
Fine.
because
So
of the
you can say
pandemic, so
that,
I didn't mention
yeah,
that,
so
sir.
you can say it's unbooked case, or she was not, she's been registered, but she has not been followed
Yes,
up
sir.
regularly. But
Yes, sir. Yes,
yeah,
sir.
that's all. That should be enough. No, I'm just saying avoid diagnosed by UPT.
Yes, sir. Yes.
Okay, we are not bothered about it. So in first trimester, I think last time I've already told you that we need specific history, specific investigation, and specific drugs which are taken by the mother. Only these three factors. So in the first trimester, we want what? We want whether the, you can remember as a mnemonic IDR. You want to know infection in the first trimester, drug intake in the first trimester, radiation exposure in the first trimester. IDR. That's what we want in the first trimester, right?
Yes.
Once you say that she's booked, you can, if you know the LMP, you can say yes, fine. Once you know that, then you just focus your history on these three parameters. That is there a history of fever? She has told us this is a fever, history of fever. What kind of fever? Fever with rash and lymphadenopathy. Okay, that will suggest that it's an indirect clue to say that there may be a possibility of intrauterine infection. Correct?
Yes, sir.
And then history of drugs and history of radiation. Yeah, Prashant, can you tell me how this history is helpful or useful in your low birth weight neonate?
We'll know the time from when the insult has happened. If it's the
Yeah,
first trimester, it's more important because the organogenesis would have started.
yes,
So there'll be more chances of congenital anomalies during if the insult has happened in the first trimester itself.
correct.
And also one more thing is, if the in this, not pertaining to this case, but if the pregnancy was not diagnosed early in the first trimester, then also if she was on any other drug intake before that,
Yes.
so that can also affect
Correct.
the
So there is
pregnancy.
a predisposition because you may have intrauterine infection, which can again result in a low birth weight infant.
Yes.
Drugs, some drugs which can cause IUGR and low birth weight, yes.
Yes.
And then radiation exposure, which can cause chromosomal aberrations and again result in a low birth weight infant.
Yes.
Correct? So these are the points which can be covered, which can be asked to you in the first trimester history. So parallelly, you should know questions which are, so what are the examples? So we'll just finish off the associated questions then and there so that we need
Yes.
not come back again at the end of history. Okay, at the end of your examination, we won't come back to history. So can you name the group of infections which are classified as intrauterine infections?
Torch infections.
Yeah. So torches in now the term is expanded. Now we call it as torches clap. Okay. So
Okay.
toxoplasmosis, others, rubella. Then you have cytomegalovirus, herpes. Now we have added CLAP to it. CLAP. That
Yes,
means
sir.
you have C will stand for chlamydia, Lyme's disease. So C is for chickenpox. Sorry, C is for chickenpox. L is for Lyme's disease. A is for AIDS, and P is for parvoviral disease. Okay.
Yes.
So this compromises the torches clap group of infections.
Yes.
And can you tell us some features of intrauterine infected babies? Like, can you give us some what if you how to identify or what problems can they have if they have or what are the telltale signs of an infected baby?
Sir, they could have low birth weight, which will
Yes, very
be
good. Yeah,
IUGR, it's small for gestational age,
correct. Yes.
and it will be symmetric IUGR.
Okay.
So if you find out by Ponderel index, other than that, on head-to-toe examination, there could be eye signs like
Okay.
there could be microcephaly. Eye, there could be clouding of the cornea, any ophthalmos, congenital cataract,
Okay.
and we could also have on checking there could be any sensory neural hearing losses,
Okay.
and cardiac defects.
Fine. Yes.
uh, there could also be midline defects along with the cardiac defects.
Okay. So fine. So Prashant has answered most of it, but it would be good to tell a few more things and specific findings of some infections. Okay. So
Yes.
at least you can make a note of that. So at least you can. So when you see a baby, most of the intrauterine infected babies are usually, as Prashant said, are small for gestation age or intrauterine growth retarded (IUGR). We'll come to a what is all this in the discussion, but at least IUGR, they usually be intrauterine growth restricted.
Yes.
Then usually they have microcephaly. Of course, some of them can cause macrocephaly also, like your cytomegalovirus. Toxoplasmosis causes both micro and macrocephaly. And then you can have jaundice, especially conjugated jaundice,
Yes.
hepatosplenomegaly. So with this combination, you will usually suspect intrauterine infections. And there could be specific findings like cataract in rubella. So you may have congenital heart defect like in rubella. You may have sensory neural hearing defect, again rubella. So you should know the triad of rubella. So
Yes.
then specific features among each. So the antenatal corroborative history which you're going to take is history of fever, fever with rash. Usually fever with rash also may be missed, but fever, rash, and lymphadenopathy is something which we don't usually miss. Okay, so you're going to ask that history, and then you're going to have a table of some of the drugs and some of. So can you name few drugs which can cause problems in if they take teratogenic drugs?
Most of the anticonvulsants
Okay, anticonvulsants. So
like
can you
phenytoin, sodium valproate,
phenytoin? Okay, so
and
phenytoin will cause what?
fetal hydantoin syndrome.
Okay, fetal hydantoin. Okay,
Uh, then if she's on other drugs like if alcohol or smoking, then also there could be IUGR. If she's has any Issues on
Yeah. So
anticoagulants
alcohol,
like
smoking,
warfarin,
warfarin.
cimetidine.
Okay. Something which we use regularly is what you would like to tell, especially in a low birth weight infant. So those who want can make a note of it.
Yes.
Like alcohol, as he rightly said, fetal alcohol syndrome.
Syndrome. Yes.
So it can cause congenital cardiac, CNS, limb abnormalities, IUGR, development delay. These can be caused by alcohol. Okay. And of course, some other drugs were specific, like carbamazepine can cause spina bifida. Carbamazole can cause scalp defects, esophageal atresia, choanal atresia. Then lithium, Epstein's anomaly, macrosomia. Lithium is something which causes a big baby, right? That's just for your interest. Phenytoin, again, is going to cause congenital anomalies, IUGR, neuroblastoma can cause. Then you can have valproate, which causes CNS, facial, cardiac anomalies, limb defects, and warfarin again, which can cause fetal bleeding, hypoplastic nasal structures. So few drugs you should know and associated anomalies. This is just for an example I've given you, that you just note down few names, few drugs, and you tell what can happen, right?
Yes.
So this is what can be asked in the first. So as I told you, in the first trimester, we need infection, drugs, radiation. Okay. Then
Yes.
we also would like to know about any drug. So folic acid, if she's already taken folic acid, and any investigation. So what investigation you would like to know in the first trimester? Whether
Uh,
she has had a baseline investigation. And second
routine.
is,
Yes.
yeah, whether ultrasound. So ultrasound was done specifically for dating scan. So dating
Yes.
scan, last time itself I've emphasized that the first trimester scan is the best scan for dating. Okay, which gives you an approximation of plus or minus 1 week. And a screening test you can do at first trimester is the nuchal translucency, NT scan, as a screening ultrasound marker for Down syndrome. Clear? So this much will be your first trimester history. Mainly infection, drug, radiation, in folic acid, plus whether any ultrasound was done for dating and NT scanning. This completes your first trimester history. Correct. Very good. Next trimester. Next trimester. Second trimester.
Sir, I think so. He's got disconnected, sir, due to some network issues.
Okay, no issues. I'll
No,
continue.
sir.
Let him join
Ah,
back. Anyway,
yes,
he's
sir.
already presented. So second trimester for we know that how do we remember what history we take for second trimester? Second trimester is the disorders due to pregnancy, okay, which begin as a part of pregnancy, or she has already had an underlying disorder and gets worsened because pregnancy is advancing. Like, so the disorders which begin in pregnancy in the second trimester, like pregnancy-induced hypertension. Yes, pregnancy-induced hypertension, diabetes mellitus. If she has already had an underlying abnormality, like for example, she has had a cardiac, she has a RHD, or she is a chronic asthmatic, or if she is say is anemic or on anti-tubercular drugs. So whatever can worsen in the second trimester or which begin in second trimester. So that specific history you have to ask, and we know with respect to today's topic, low birth weight infant, the specific history of pregnancy induced hypertension is more important because they're going to get compromised. Yes, IDM, you can get a small infant when the diabetes is before pregnancy, when she is acquired. Like, for example, she's already a known diabetic, and then she is definitely going to have a small for gestation. It doesn't mean that all diabetics, if it is pregnancy induced hypertension, if it begins in the second trimester, then you're going to have a macrosomic infant. If she's already a diabetic, then she may likely end up with may likely with an SGA, poorly controlled, already diabetes. She's already known diabetic. She'll have a small for gestational age baby, right? And the second trimester, as I told you, we need to know about iron and folic acid. We need to know about the scans. Specifically, the scans are for knowing the anomaly. So 18 to 22 weeks, you look at the anomaly scan. So three things we need in the second trimester. One is disorders beginning in pregnancy, or if the underlying pregnancy, she already had a cardiac defect, she already had anemia, that can worsen. And from today's point of view, we want to know these are the disorders which can affect pregnancy and can lead to low birth weight. So that's how the second trimester is important, and whether she has taken her iron and folic acid. Okay. So coming to the third trimester history, we want to know anything complicating delivery. The same thing. Those disorders, what happened to her PIH, what happened to her diabetes, what we can just follow them up. And second thing, the third trimester, we are worried anything which can complicate the delivery. Which, as in this case, what he presented, Prashanth, he said there is pain abdomen, there is leak PV or abrupt show, placenta previa, or it could be a leak PV, fever in the mother, UTI in the mother. So anything of these sort which can affect outcome in the first 1 week of life, which can lead to early onset sepsis. So that's how what you're going to concentrate on the third trimester. And very beautifully he has brought up, especially in a low birth weight infant, we need to know about the weight gain in pregnancy. We know that the average weight gain is around 11 kgs. So here approximately it was around 15 kgs. Okay, that's fine. But she's been a worker, she has told, and blood pressure was in. There's no history. Yes, okay, there's no history. Fetal movements are supposed to be, you know, that by 16 to 18 weeks earlier in her primary, and then decrease fetal movements, or if she has undergone any new extra investigations like an NST, or if she's had a biophysical profile, those things can be added if you know, or if she tells that these things were done, you can add it, which tells us about. And one more history is that biophysical profile itself will give you a about the amniotic fluid index. You can also look at, ask whether Leica volume, did they tell you the Leica volume was less or more? That gives a clue that the fetal, it gives a clue to us about the fetal well-being. Suppose the fetal well-being is not good, baby is not doing well, you can have oligohydramnios, you can have the consistent weight. So she may feel that the abdomen, suppose she's a second baby, she will say that she may not, she felt always the baby is small, maybe her abdomen is small. So like that you can get some clue from the history that one is weight gain, second is progression. Either she would have done the ultrasound and the ultrasound is showing that there is a decrease in the weight of the baby. So, or there's, if she's falling off centiles, if they are plotting on the ultrasound graph, if it's falling off centiles, you may get a clue, yes, so this may be a low birth weight unit, correct? So these are the history you may have to ask in the third trimester. If she's followed up by scans, if she has done any biophysical profile, is there any clue which can tell us that it could be a low birth weight infant? Fine. So Prashanth is back. Hello, Prashanth?
Prashanth, can you hear us?
Hello?
Yeah.
Hello,
Can
yes,
you
sir.
hear me? Yeah.
Yes, sir. There was a power off. I came up on the terrace. Now I can. Yes. Sorry, sir.
No issues. So we just
Yes.
told that we were just telling that what are the specific history we need to take in the second trimester,
Yes, sir.
and what you have written is correct. We need to take about the maternal disorders which
Yeah.
can affect pregnancy. As a result, today's case, PIH, diabetes if it's a pre-existing diabetes, and then if she has anemia, chronic infections, or if she's having a chronic RHD, if it's a congenital heart disease she has, then that can worsen in pregnancy and can result in a low birth weight infant. Okay, so
Yes, sir.
abnormality of the placenta, placentation, or abruptio placenta, placenta previa, or bleeding PV, leak PV, etc. in the third trimester. And any follow-up scans have been done. If they have shown that, okay, baby is not doing well, it's not gaining weight, and other things, if you have got by antenatal history, you can tell. And the Leica volume, if she knows anything about Leica volume, like if she says that the Leica volume was decreased, doctors told the Leica volume, these are the things which will tell us that the fetus is doing well in the
Yes, sir.
in utero period, right? So in first trimester, I require IDR, infection, drugs, radiation. Drug wise,
Yes,
I want to know folic acid. Investigation wise, I want to know the first trimester's dating scan and the NT scan. Whereas in second
yes,
trimester, I require diabetes, hypertension, chronic maternal illnesses which can worsen during pregnancy, whether she has taken iron and folic acid as per the drug is concerned, TT, and then we want to know investigation, that is anomaly scan.
yes,
Okay.
sir.
And specific screening for Downs in second trimester will be absence of nasal bone length decrease. That will be another add-on point, or specific findings if you have for Downs, if like you have echogenic bowel or you have a short femur length. So, and then growth is going to be monitored by abdominal circumference and length. In the first trimester, we use crown rump length. So you need to know some parameters. In the first, in the ultrasound, we use crown rump length, then femoral length, and abdominal circumference, and whether any centiles were falling off, which will tell us that probably the baby is not doing well, and you may result in a low birth weight baby. If she may know or may not know the
Yes, sir.
weight of the baby, right? So
Yes, sir.
till the trimester histories, is there any doubt? I think you're clear on that.
Yes, sir.
Okay, and the associated questions also I have told you. What can be
Yes.
etiology questions? Basically, it will be etiology questions, which will come back again in the discussion. In the last half an hour, we'll have discussion on low birth weight. Okay? Yeah,
Yes.
you go ahead. Yeah.
Natal history. She developed lower abdominal pain, which is intermittent, increasing in frequency, intensity, and duration, radiating to back and the other side of thighs, and associated with leak per vaginum, suggestive of labor pains, which she developed on the early hours of 14th December. She was rushed to the hospital, and after an initial assessment, she was told that she was in labor, and she was shifted to the labor room. The first baby was born after 14 hours of labor. It cried immediately after birth and weighed 1.9 kgs at birth. The second baby was born by vaginal delivery after a gap of 25 minutes after the first twin. It did not cry immediately after birth and needed resuscitation. It weighed 1.8 kgs at birth. Both the twins were shifted to NICU in view of low birth weight, and the second twin having not cried at birth and having required resuscitation.
Okay.
Shall I proceed?
Yeah. So yeah, we'll just stop at this. In natal history, definitely, as he told, that we need to know what probably the entire description of the pain abdomen is not required for pediatrics. For us, most important, we want to know, is there a prolonged rupture of membranes? We want to look at history of which is suggestive of which can lead to early onset sepsis, correct? So we want to look at risk factors for sepsis. So you can tell us duration of labor. Suppose if it is more than 24 hours, first and second stage, including both, is equal to more than 24 hours, then it's a risk factor. If there is a PROM, premature rupture or prolonged rupture of membranes of more than 18 hours, that again is significant. If she has had multiple vaginal examinations, or if she's having foul smelling like her, if she had any fever, these are the risk factors for sepsis. Okay. Then we would, that's what is important. And the native history, the mode of delivery, is it LSCS, instrumentation, which we know that they could complicate the delivery. And then, baby condition immediately after birth. That means we want to know, did he have a smooth transition? Did he cry immediately after birth? Did he require any resuscitation? And then, as you know, the second of the twin, once the placental supply is cut off, you know that he is more prone for asphyxia. And therefore, the second twin, you can see in this, as it happens classically in twins, that you have the second twin being asphyxiated. So we'll also discuss about the problems of twins at the later. Now, I just don't want to disturb you on that. So we'll go through the problems of this. So here we are having two babies who are low birth weight, and one was okay. He had a smooth transition. Because of his low birth weight, I think they shifted to NICU. The other baby, post asphyxia, probably for post resuscitation care, he was shifted to NICU. Fine. Right. Next.
Postnatal history. Expressed breast milk was given to both the twins starting 3 to 4 hours after birth in the NICU and was continued regularly. Both passed meconium and urine on the same day, and they were shifted to the mother's side on the 5th day of life.
Okay. So mainly for feed establishment, they had took some time, because these babies, will see why they might have shifted to the NICU. We will see in the discussion. Okay. Next.
Yes. Feeding history. No prelactal feeds were given. Express milk was given through the help of a paladi. During the NICU and after NICU, it was given on demand every 2 hourly, both during the day and night. And each twin was breastfed from one breast exclusively, and about as much as they were able to feed, about 2 to 3 paladis full. Both the twins were passing urine regularly and slept for 2 to 3 hours after each feed.
Okay, fine. So here in feeding history, the associated questions which can come for you is, how do you decide, or what decides the feeding of the low birth weight infant? Okay, I'll just finish off. This feeding can be a definite problem in our low birth weight babies. We'll see how we classify low birth weight babies based on gestation. He could be low birth weight because he is preterm, or he's low birth weight because he's small for gestational age. Okay, small for gestational age is gestation will be more. So therefore, the method of feeding can be different. Or if the baby's weight is less, then also the method of feeding is different. So how do we decide? Can you, Prashant, can you tell when do you decide, okay, this baby can go for direct breastfeed? This baby, I'm going to put him on OG feed. This baby, I'm going to put him on Palladi feeding. So feeding of low birth weight infant could be a theory question also. So do you have any idea about it?
Yes, sir. We always try to establish breastfeeding as much as possible. But for
Okay.
breastfeeding, the preterm infant needs to have uh, good rooting, sucking, and swallowing, and coordination in between these, which are
Yes.
not developed in preterm.
Yeah.
So, based on the gestational age and the development of the, if the, if it's less than 28 weeks, which by when these none of these would have developed, we
Okay.
usually start on IV fluids. And if
Okay.
it's between 28 to 32 weeks, we can give oral feeds through an NG tube. And coming to 32 to 34 weeks, they usually try with the Paladin and oral feeds without an NG tube. After 34 to 35 weeks, we can usually start with breast milk, direct breastfeeding. But since they're preterm and they will
Okay. Fine.
lose a lot of energy while sucking and swallowing. So we usually ask the mothers to start initially with breastfeeding, but then afterward give them express breast milk so that both the stimulation will not be affected and the babies also will not get fatigued just
Fine.
because of
Okay.
breastfeeding.
So Prashant is right. So we'll just modify the answer a little bit. So based on the maturation skills, the feeding skills of the baby, it is decided. Whatever he said is right. So about 34 weeks, you would say that the sucking, the sucking, breathing, the coordination between sucking, he needs to do three things at the same time. He needs to
Yes.
suck, he needs to breathe, and he needs to swallow. Baby is swallowing amniotic fluid right from 16 week onwards. So swallowing is never a problem. It is a coordination between breathing and swallowing. Breathing and swallowing occurs by 32 weeks. So that's why above 32 weeks, you can transit to Pallada feed, where he may, the Pallada feeding or spoon feeding, where he is able to, he can swallow and he can breathe also. And 34 weeks, suck, swallow, and breathe coordination will occur. And that's why you put the baby on direct breastfeeds. Is it clear? So at
Yes.
above 34 weeks, suck, swallow, breathing coordination will occur. So above 34 weeks, you can try direct breastfeeds. But again, in late preterm, this latching attachment is always a problem. So the feeding issues, they are going because of it matures from 34 weeks to term. So they can
Yes.
also have issues with latching and breathing. So you, as he said rightly, that you can put them on direct breastfeed. If they're not taking, then you may have to try Pallada feeding. And once rooting, sucking, swallowing, the latching is better, the baby is able to suck, swallow, then you can put him on direct breastfeed. So the idea is the suck, swallow, breathing occurs at 34 weeks coordination. So therefore, you put them on direct breastfeeds. 32 weeks, swallowing and breathing is there. So you can try Palladi feeding. Below 32 weeks, as he said, below 28 weeks will be because your intestines, only MMCs will be there, motor migrating complexes. The peristalsis is not well established. So you put them on IV fluids. 28 to 32 weeks, you put them, you start trophic feeds and slowly increase as with gut maturity. Now peristalsis has just started and he has immature sucking bursts, whereas he won't have coordinated swallowing. So therefore, 28 to 32 weeks, you put them on IV fluids and gradually step up, and then you shift over to Pallada feeds when he's 32 weeks and 34. So the numbers you're going to remember is 34 weeks, direct breastfeeds, because suck, swallow, breathing occurs. 32 weeks, Pallada feeding, because breathing and swallowing has occurred. 28 to 32 weeks, predominantly OG. Then, as and when so protein sucking is better, you shift over to Pallada feeding. Below 28 weeks, predominantly IV fluids. Okay, and you give
Yes.
something called as minimal enteral nutrition or just development of the gut.
Yes.
Okay, so this much you should be knowing as far as feeding of low birth weight is concerned. Fine. Next.
And also, sir, about any the HMF that is given for preterm.
Yeah, we'll discuss that when we talk about management of low birth weight. Okay,
Okay, sir.
fine.
Immunization history. Both the twins are have received hepatitis B, vitamin K, and BCG.
Fine.
Family history, it's not a concern in his marriage, and there's no history of twinning in the family.
Okay.
So in socioeconomic, they come to upper lower socioeconomic groups.
Fine. How is socioeconomic history important in this?
Because it's preterm, the associated cost might be more than the ability to care for the babies.
Yeah.
And
So low birth
in
weight,
particular to twins,
for low birth weight
also.
itself. Cause for
Sorry,
low
sir?
birth weight itself could be low socioeconomic status.
Yes.
Okay,
Sir.
poor maternal nutrition. Mother itself
Yes,
is a small SGA. She begets a SGA baby, and the other baby, she following that also she'll have that's a vicious cycle. Okay,
Yes.
so that's the reason why you need to know about socioeconomic history with this respect to low birth weight. Yeah, carry on.
Examination, both the babies were examined supine in the wards. Baby 1 was alert and active, and baby 2 was asleep. Sir, from here onwards, I've given only the details of baby 1. Attitude, the baby 1 the thighs were abducted, externally rotated, and semi-flexed, semi-flexed at the knees and elbow. Vitals, heart rate was 160 beats per minute, regular, which is normal. Peripheral pulses were felt. Respiratory rate was 45 cycles per minute. Periodic breathing and abdominal type, normal. Blood pressure was 60 by 40 mm of mercury, and temperature was 36.5 degrees Celsius. Capillary filling time was less than 3 seconds, it was around 2 seconds, and there was no yellowish discoloration. Anthropometry, birth weight was 1.9 kgs, which was appropriate to gestational age. Present weight was 2 kgs, which has regained the birth weight by 11th day of life. And length 44 centimeters, it came to between 20 and 50th centile, and head circumference as well between 10th and 50th centile was 30 centimeters, which is more than the chest circumference of 26 centimeters. Quadrennial index was 2.2. And hello?
Yeah. Carry on.
On Fenton's chart, we can see that the all weight, length, and head circumference was between the 10th and 50th centile.
Okay, you can go back to that. Just go back to that.
Yes.
Yeah. So here about the other things we'll discuss since the chart is here. I'll just finish it off here itself. So when you want to plot, as I said, we want to divide the babies as far as gestation and weight is concerned, correct? We classify them as on gestation, we classify them on weight, and then we classify weight and gestation. So as he rightly said, this baby is 35 weeks. So we want to know 1.9 or 1.6 is below the 10th centile, or it's between the 10th and 90th centile, or it's above the 90th centile. So here, according to you, what is it? Is it below the 10th centile? Prashanth, is it below the 10th centile?
Prashanth, you're not audible.
Okay, fine. Till he comes back. So you know that I told you, you can see that mark, he has plotted it on the 10th centile. So probably he's just on the 10th centile. And you see the head circumference length also is almost, he has plotted it there. So I just wanted to tell you that plotting is just by putting a dot. Okay, it's not crossing or circling it. So you just put a dot. And what here I would just want to finish off how I classify my SGA babies. Okay, so in SGA babies, we divide them into two, as he told us already, that we can divide them into based on the ponderal index. Now, what is ponderal index? So ponderal index is when we divide weight in grams divided by length in centimeter cubed into 100 will give you a ponderal index. The ponderal index gives us a lot of clue to say if the value is less than 2, then we say he's a asymmetrical IUGR. Asymmetrical IUGR. Suppose if it is more than 2 or 2, then we say it is probably symmetrical IUGR. Now, how does it help us? How do you think it helps us? So it helps us to identify the insult when the insult has occurred. So suppose if he's a symmetrical SGA, there is definitely the affection is both in cell number as well as cell size. So when cell number and cell size are affected, probably the insult is either in the first trimester or early second trimester. So therefore, the baby will be small, right from the head, abdomen, and the entire length also will be small. So that is how you identify a symmetrical SGA. What is the spondyl index? It will be above 2. Whereas asymmetrical IUGR will be usually when the insult is occurring later part of pregnancy, second trimester onwards. Classical example will be your PIH or something beginning in the second and the third trimester, anemia. So you can see that where the cell size is okay, mean the cell number is okay, whereas the cell size is a problem. So therefore, this baby will have a head sparing effect. Usually asymmetrical IUGRs will usually have the head which is normal, whereas the others are head which is large, the body, the abdomen, and the length will not be affected. Okay, so that's how you look at, why the asymmetrical IUGR is helpful in ponderal index. Suppose your ponderal index is, you're having a problem. So what you can do is you can plot the head circumference, length, and weight in this chart. Like what he has done, we can plot it on the Fenton's chart. Suppose if all of them are below the third centile, or you can see if everything is below the 10th centile, everything is low, it's on the similar centiles, then you put it as symmetrical SGA. Suppose if only the weight is less, whereas your head and length, head circumference and the length is okay, you put it as asymmetrical IUGR. That's one thing which I wanted to stress at this level. So you have to plot him on the graph, you calculate the ponderal index, you say it's asymmetrical or symmetrical. The other way of doing it from the chart is, if only the head circumference and the length are in normal centiles, but only the weight is less, then he's asymmetrical. Suppose if all three are below the 10th centile, then you know that both head circumference, length, and thing, then he's more likely to be a symmetrical IUGR. Okay, fine. Go ahead. Are you back?
Yes, sir.
Yeah.
Modified Ballard score. Neuromuscular came up to 14. The posture was semi-flexed. Square window was 60 degrees. Arm recoil was less than 90 degrees. Popliteal angle was 120 degree, 100 degrees. Scarf sign, the elbow came up to the midline, and heel to ear, it came up to score 2.
Okay, fine. So in the exam, we would also we may give you a chart, so you need not by heart this, but just need to know the name. So how
Yes.
do we? So first is, of course, the best is LMP, first trimester scan. If after the birth of the baby, if you want to know the assessment of gestational age, one
Yes.
of the scores which you're going to do is the modified Ballard score. So the other score, you have Dubovitz score, Parkin score. A CAN score is a where you can make out which will suggest intrauterine malnutrition. Suppose you want a score to assess intrauterine growth retardation. If you want to say signs of clinical assessment of nutrition status of a baby, if it's small for the, you have something called a scan score. These are the associated questions they may ask you, but at least you should know gestational age assessment is based on modified new Ballard score or modified Ballard score, and it has physical components as well as neuromuscular
Muscular
components.
component.
Okay, so in physical components, you know that you're looking at the skin, you're looking at lanago, you're looking at the breast bud, you're looking at the genitalia, you're looking at the sole creases. This is what you have to look. Okay, whereas in neuromuscular, we have some angles which he mentioned. So the heel to here, popliteal, posture, the square window. These are some of the neuromuscular criteria which will come, and you can assess babies up to, so you can say that till when can you use Ballard scoring? You can see that the score, you have a score there. So you can say that the least score and what is the maximum score. So you can know till when you can assess these babies, right? So according to how much score you get, you say that this much is the approximate gestational age. Fine, fine, go ahead. For undergraduates, I think if you know which modified new Ballard score or modified Ballard score, if you know the name, that should be enough. Okay,
Okay.
fine. Next, go ahead.
So it came up to 34 weeks, which was 34 plus or minus 2,
Fine.
according to examination. On head
Fine.
to toe, the head appears normal in shape, size, and is bilaterally symmetrical. Anterior fontanelle admitted 2 fingers and was 3 into 3 centimeters. Posterior fontanelle also admitted 1 finger. The face was normal. There were no bruises or dysmorphic faces. Eyes were normal. There was no, there were eye movements were present in all directions. Doll's eye movement was present and light reflex was positive. Ears were normal in size, shape, and position, and elastic recoil was slightly reduced. Oral cavity was normal, was wet with pink mucosa, and there was no cleft lip or cleft palate. Neck was normal. Chest was normal in shape. Apex beat impulse was felt at the fourth intercostal place, lateral to mid-clavicular line. Abdomen appears distended, which is normal, and liver was palpable. The span was 5 centimeters. Umbilicus, the stump was swollen. There was no periumbilical redness or discharge. The genitals, labia majora was not covering the minora, and there was no discharge or bleed per vagina. The spine was normal, and there was lanugo present on the back.
Go ahead. Go.
Yes. Systemic examination, abdominal examination. The abdomen appears distended. The corresponding quadrants move with respiration. The umbilicus was normal. Liver was palpable 3 centimeters below the costal margin. The span was 5 centimeters. On auscultation, bowel sounds were heard. Uh, Systemic examination, central nervous system. Baby was alert and active. As mentioned, the attitude was semi-flexed. So I've also mentioned the cranial nerve examination based on just the observation. The the baby, we observe the baby when it was breastfeeding. So the baby used to turn towards the pallidi with breast milk, suggestive of intact first cranial nerve. Second, the light reflex was present. 3, 4, and 6, there was normal eye movements in all directions, and there was no ptosis. The fifth cranial nerve, rooting sucking reflexes were present, suggestive of intact fifth cranial nerve. There was no deviation of angle of mouth on crying or drooling, suggestive of intact seventh cranial nerve. And there was startle reflex was elicited. Also, acoustic brain reflex was positive. Ninth and tenth were intact. There was no swallowing, drooling or regurgitation. There was swallowing reflex was present. There was no deviation of the face or undue prominence of the sternocleidomastoid muscle, suggestive of intact 11th cranial nerve. The tone was normal in all 4 limbs, and all the 4 limbs were semi-flexed. Normal activities was present in all the 4 limbs. On neonatal reflexes, Moro's reflex was incomplete. Abduction, extension, and fanning of fingers was present, which was followed by falling of the limbs on the bed with no adduction or flexion. Palmar plantar grasp were elicited. Rooting, sucking, and swallowing were present. Also, asymmetric toning reflex was present. Deep tendon reflexes, biceps, triceps, knee, and ankle were elicited. Babinski's sign was positive. The cardiovascular and respiratory system were normal. Musculoskeletal system, Otto-Linear Barlow test was done, and there was no DDH.
Yes, your diagnosis.
Diagnosis: low birth weight, preterm, appropriate for gestational age, with no obvious external congenital anomalies, and was evaluated for normal newborn care.
Okay. So good presentation, Prashanth. So most of the things he has covered on examination. So means last time, I think in the last presentation, we had discussed everything about examination, starting from general physical examination to the specific system examination. And I've also given, I think, the case sheet, what is supposed to be written, the order, everything I think was discussed. So this time, I'm not going to go into details, though he presented everything, which was very good. But usually, when you get a low birth weight case, we don't expect you to examine in so much detail about the neurology. We don't, because usually we know when we do a Moro, it will be incomplete, because it has a phase 1 and phase 2. Phase 1 is usually present, whereas phase 2 in usually absent in preterms, so it may not be complete. So if you do it, yes, you do it and tell. And as he said, cranial nerves, it's just assumption. We don't we say that based on whatever movements he has, what is seen, means if you see the angle deviation, or if you see the eye movements or blink response, startled response, we assume that and we saw that the sucking rooting is good and he's swallowing, so therefore we know 10th and 11th and 9th and 10th is fine. So therefore, we assuming those movements, we are going to say that it is normal. And systemic examination also, we may not ask you much. But definitely, we will ask you what you would expect. Now, suppose if it's an IUGR baby, as I already mentioned, that if it's an IUGR baby secondary to intrauterine infection, what you specifically look at. So as previously Prashanth said, you may look into the cataract, or you may look at hepatosplenomegaly, you look at jaundice, you look at petechiae, you look at some specific spots like blueberry muffin spots, you look at microcephaly, you look at macrocephaly. These are the specific, or some limb anomalies. So you are going to look at specific findings. So in a low birth weight infant, they may ask you, what do you see if it's an intrauterine infected baby? Or what is the stature, what is the difference? What difference will you see if it's a symmetrical IUGR or an asymmetrical IUGR? As I told you already, that in a symmetrical IUGR, more likely all the cell number and the cell size are affected. Therefore, the baby will be small right from head to toe. Means both, he'll be small head, small abdomen, small, the length also will be small. Whereas asymmetrical usually has a brain sparing effect. The head is large, whereas the others are of normal size. That you can see that the chest and this one is normal size. So because of lack of time, I think I will just go to the associated questions which can be asked in the low birth weight newborn. Because this examination, everything was discussed in the last presentation, we thought we'll just discuss the next half an hour what are the possible questions which you can get in low birth weight and how to prepare about them.
Yes.
Is that okay?
Yes, sir.
Do you want me to go through the examination again, or
Sir,
we'll just
I
go to
had just
discussion of low birth weight?
one doubt, sir, because there was a resuscitation here, and if there was any history of asphyxia, should we do the central nervous system in detail, like how I've written here, or is it not required? Hello?
Prashanth, can you hear me?
Yes, sir. Hello? Hello? Yeah, hello? Yes, sir?
Hello?
Yes, sir. Am I audible? Hello?
Hello, Prashanth?
Yes, sir.
I think your volume is quite low. So as I was telling you, the presentation was good, whatever
Yes,
you
sir.
told about the examination and thing. But in a low birth weight infant, we expect the questions more on discussion. Discussions will be more. And since last time we had already discussed on examination and associated questions on examination, I've given you the format also. So this time we'll just base our discussion on low birth weight.
Yes, sir.
Is that fine?
Yes, sir.
Okay, so fine. So now, Prashanth, can you tell us how in low birth weight, a baby can be low birth weight because of, he could be a preterm, or it's because he's a small for gestational age. Is it clear?
Yes, sir.
Correct?
Yes, sir.
Okay, so he could be small because he's a preterm, or he could be small because he's a SGA. Okay, and in SGA, we've said that he could be small for gestational age. It could be, now there could be, there's another term which is IUGR. Now, what exactly do we mean by SGA and what do we mean by IUGR? No, SGA means that when you are comparing this baby with respect to the population, you put them as SGA. Correct? But when you say that definitely there are signs of in utero growth retardation, that means you're following up the baby and the baby is falling off centiles from in utero period. And when the baby comes out, he shows signs of in utero growth retardation. Then you put the baby as IUGR. SGA means he's gestine. He's constitutionally small. He's constitutionally small. He's gestine. When you compare to the population, he's small. Whereas IUGR means in utero, there should be signs of faltering of growth. Clear?
Yes, sir.
And in IUGR, I said you can classify them as asymmetrical or symmetrical based on the ponderal index. Okay. Now, the first question which can be asked in the low birth weight infant, I told you this is how you classify them based on weight. You can do it, and then based on whether is a IUGR or SGA or preterm. Correct. Now, can you give me some causes? What could be the factors responsible for low birth weight infants?
First, we could have
etiology of low birth weight infants.
Yes, sir. There could be congenital anomalies.
Okay.
We divided fetal or maternal causes.
Okay.
Etiology. fetal, it could be congenital anomalies or any chromosomal disorders, or it could be constitutional also as well if the parents are also stunted.
So fine. Yeah, Prashant
And
was right. His volume is a bit low, so I'm not sure how many of you can hear him. But as he said, that you always classify the causes. So you classify them as maternal factors, you classify them as uterine factors, you can say fetal factors, and others. Okay. So maternal factors we already discussed. It could be low socioeconomic status, anemia in the mother, maternal malnutrition, drug intake in the mother, maternal smoking, preeclampsia, anemia. If she's having chronic underlying medical illness like heart disease, renal disease, uterine anomalies like biconvate uterus, cervical incompetence. Fetal factors are whenever there is in utero fetal growth restriction because of fetal distress, or babies having, there are twins, as in this baby, the cause for SGA, of course, here the baby is on 10th centile for 35 weeks, but the baby is low birth weight because he is one of the twin. So he has to share his nutrition among the twins. If there's an abnormal placentation, okay, placental dysfunction, placenta previa, abruptio placenta, all these can cause low birth weight. Okay, so first important question you have to prepare for low birth weight is the etiology of low birth weight. So as he rightly told, we classify them as maternal causes, fetal causes, and others. So that's how you classify the low birth weight infant. Okay. Now we look at what are the problems you expect in a small for gestational age babies, an IUGR baby. What are the problems you expect in an IUGR baby? What are the problems of prematurity? These two questions are very important, and anywhere they can ask you some questions on that. So now let us look at what are the problems of SGA babies. What are the problems of premature babies? Prashant, can you tell me few problems of SGA babies?
sir, SGA babies, they are small for gestational age, but they would have matured. Some of the reflexes would be normal, the weight would be less. So, the problem will be with their catch up growth, nutrition, hypothermia. They're more prone for hypothermia, and they were also more prone for dehydration because of increased insensible water loss.
Okay, so better way of remembering what are the problems of these low birth weight SGA babies or IUGR babies is that the problem starts right from birth. So you remember like that. What are the problems can I expect at birth? What are the problems I can expect after birth and in the due course of time? Okay, that's an easy way of remembering it. And then we'll see specific systems. RS, what problem you can have, CVS, what problem you can have, CNS, what problem you can have. So like that, if you divide it, it's very easy for you to remember also. So now let us look at two things. One is in a if it's a preterm baby, we'll discuss second. First, let us finish off the SJ babies, because among the low birth weight babies, we know that 60% is contributed by your SGA babies or intrauterine growth retarded babies. SGA babies are 60% of these low birth weight babies. 40% is contributed by prematurity. Okay, so here we want to know what are those problems of these SGA babies. India has a lot of SGA babies. So I said 60% of your low birth weight babies are SGA or small for gestational age. So what are the problems they can expect? So as I told you that if these are small because there is already an environment which is compromised in utero, correct? So you expect in utero hypoxia. So the moment you say in utero hypoxia, these children are, these newborns are more prone for birth asphyxia. So what problem can they have at birth? They can have birth asphyxia. Okay. And since, as he said, they're relatively mature, already you have intrauterine hypoxia there, that can cause acetylcholine release and relax the sphincters, and therefore they can pass meconium. So they can have meconium aspiration syndrome. So at birth, two problems can happen in SGA babies. One is in birth asphyxia. Second is meconium aspiration can happen. Then during transport, you know that these babies are going to have less subcutaneous fat. Therefore they are going to be more prone for hypothermia. So they're going to be more prone for hypothermia. Then what are the problems can happen and in the NICU? Once they reach the NICU or once they reach the ward, what problems can they happen? So I told you first, birth asphyxia, meconium aspiration. Then once they are in, during transport, they can be hypothermia. And after that also, hypothermia is one of the major killers of low birth weight. Okay, so hypothermia, and then metabolic problems. So metabolic problems are very common in these small for gestation age babies or low birth weight babies. The reason is because they have less substrate. You and me have a lot of glycogen storage, so we can maintain our sugars. So their most important problem is hypoglycemia. And all the stores are less because you know that the transfer occurs during the last trimester. So therefore, they are going to have all stores are going to be less. So they're more prone for hypoglycemia. They're going to be hypocalcemia, hypomagnesemia. They're going to be more common in these SGA population as far as metabolic problems in these SGA babies. Then when we look at individual systems, now let us look at the CVS, the RS, central nervous system, bone marrow, liver. What are the problems at each organ system? Now in CNS, what do you think are the problems of CNS of SGA babies?
Sir?
CNS, what problems do you think
Yes,
you
sir.
expect in SGA babies?
Sir, there could be, they usually are mature, so all the reflexes would be normal. But
Okay.
since they're more prone for birth asphyxia, there could be
Okay.
HI.
So yes. So if they have birth asphyxia, then you know that probably they're going to have development delay, cerebral palsy later. But one of the important things, that's why it depends upon, again, it boils down to whether it's asymmetrical or symmetrical. Symmetrical, usually we have genetic causes, chromosomal causes, as Prashanth mentioned, genetic causes, chromosomal causes, or intrauterine infection causes. So usually they are small, and therefore the brain, they can have a specific neurodevelopmental problems if they are dysmorphic, or if they are syndromic, or if they are chromosomal disorders. They can have neurodevelopmental outcomes. And definitely if they have intrauterine hypoxia, if they have small head size, they can have neurodevelopmental problems. Whereas one characteristic part of asymmetrical SGAs, the asymmetrical IUGRs usually catch up growth, whereas your symmetrical SGA will always be below the third centile. They will always be below the third centile, whereas asymmetrical SGA usually catch up growth, because I told you there's relatively head sparing effect. But they will have some abnormalities, like they will have learning problems, like they will have arithmetic problems, behavioral disorders, hyperactivity disorders. They will have asymmetrical SGA more prone for hyperactive disorder, hyperactivity, or their ADHD, or they can have mathematical problems. They can have specific learning abnormalities as far as CNS is concerned. So coming to our respiratory system, what is the problem specific to SGA babies? Preterm will discuss a little after
respiratory
this.
respiratory distress syndrome, because
Yeah,
of
respiratory distress syndrome more common in preterm. I'm talking about SGA. So SGA, for some reason, we have a important condition called pulmonary hemorrhage. So pulmonary hemorrhage is more common in SGA babies. Okay. Similarly, the GIT. So GIT, what problems can happen in SGA babies? So you know that the feed in most of them will have abnormal Dopplers. There's some in utero compromise to the circulation of the gut. So they're more prone for necrotizing enterocolitis. There's a condition called necrotizing enterocolitis, is more prone in feed intolerance and necrotizing. That's why it takes some time for us to establish feeds in these babies. Okay, so necrotizing enterocolitis or feed intolerance is common in these low birth weight SGA babies. And of course, they're more prone for jaundice. Bone marrow, you know, there's intrauterine hypoxia, so there's more erythropoietin, and therefore they have more blood. That's means they have polycythemia. And because of polycythemia, also they can have jaundice. Okay, so therefore these are some of the specific problems of SGA babies, but these are all short-term problems. Now, what happens to the long-term problems? Long-term problems are two. One is neurodevelopmental sequel. Second is growth. I told you symmetrical SGA usually will be in the less than third centile, whereas asymmetrical SGA, they usually will catch up growth after 2 years, but they have problem with specific learning disorders, ADHD, etc. And one problem specific to your SGA babies in the long term are more predisposition for syndrome X. Okay, that is metabolic syndrome. So that is your hypercholesterolemia, CHD, cardiovascular disorders, hypertension, diabetes mellitus. So they are more prone for syndrome X or metabolic disorder. Is it clear? So now if you look at problems of SJ babies, just to summarize, problems of SJ babies at birth is birth asphyxia, meconium aspiration. Then during transport and afterwards, they are more prone for hypothermia, which is a major killer. And then I told you specific abnormality, CNS, RS, they're more prone for pulmonary hemorrhage. If you look at GIT, feed intolerance, NEC, then if you look at, they're more prone for shock, so cardiovascular system abnormality. Then I told you that they are more prone for jaundice. They have, because of in utero hypoxia and more erythropoietin, they have more polycythemia and problems of polycythemia. And then I told you that they could be chromosomal or dysmorphic features, so they could be having congenital abnormalities because of that, because they're SGA. And then I told you that the other important long-term problems are growth and predisposition to metabolic disorders or syndrome X. And all of us know that low birth weight baby means low immunity, so they're more predisposed for infections also. Fine. So these are the problems with respect to SGA babies. Now let us look at problems of, before I finish SGA babies, one last question is, they will ask you differences between symmetrical and asymmetrical IUGR. And I've told you the problem specific for them. The other way is looking at the baby when he's born. Can you say that there are, okay, this baby is an intrauterine growth retarded babies. There are some clinical signs of intrauterine growth retarded babies. So for which you look at three parameters. One is you look at lack of subcutaneous fat. So if there is no subcutaneous fat, lack of subcutaneous fat, or the gluteal fold is more than 3, you can see gluteal fold more than 3. Old man look, gluteal fold is more than 3. If you have lack of subcutaneous fat, and if you measure the head circumference and the chest circumference, the head circumference is usually more than 3 centimeters compared to your chest circumference. These are some of the signs, telltale signs of an IUGR baby post birth. And there is a score I told you, which will tell you about in utero growth retardation or malnutrition. That's called CAN score, Clinical Assessment of Nutritional Status Score. Okay, at least you know the name, that should be enough. So these are all the questions which can be asked to you as far as SGA babies are concerned. Now let us look at prematurity. Prashanth, can you tell us some specific problems related to prematurity?
The prematurity, they will have, first of all, develop their reflexes and their developmental will be affected. So there'll be problems with feeding and attachment to the breast, as we already discussed. And other than that, they'll also have underdeveloped respiratory system. So there could be respiratory distress syndrome because of that. And
okay, fine. So Prashanth is right. So what we'll do is we'll try to similarly, how did we do for SGA? The same thing we'll do for preterm. So you classify based on the systems. Then it's very easy for you to, you go from head to toe like that. You look at specific problems in the head. So what could be specific problems in the head, Prashanth?
Specific problems in the head, there could be
neurological problems. Yeah.
There will be more prone for birth asphyxia. So again,
so I told you SGA are more prone for birth asphyxia. Preterm can also have birth asphyxia. Yes.
Yes.
Because of immature.
Sir, they have immature capillary, so there could be more prone for bleeding.
IVH, intraventricular hemorrhage. Very good. Yes.
They could, if associated with any other disease, there could also be a microcephaly.
Okay, fine. Well developed. So if everything is not, so you have short-term problems. The immature capillaries, the cerebral blood flow is not well regulated. So you have enough inadequate supporting structures. So there could be any variation in the blood flow because of various reasons. You can have blood, the capillary breaking, and you can have intraventricular hemorrhage. Very important. So one of the important complications of prematurity is intraventricular hemorrhage. And you know that the brain is still developing. So therefore, any insult at that point, and the dendritic structures are just connecting to one another. So it's not fully developed. Myelination has not yet occurred. So therefore, he's definitely in a preterm. They are going to be problems in long-term neurodevelopment outcome, and therefore we need to take care of the baby very well, so that we get a proper, there are some things we do in the NICU which helps him for long-term neurodevelopment outcome is better, because as I told you, the brain is not yet fully developed. Second is the connections are also not very well developed, so they are more prone to some, because everything end supply, the blood supply to certain specific parts of the brain are going to be affected, and there's a lot of problems can happen with relative to neurodevelopmental outcome, and that's why we monitor them. And one of the important things what we do at follow-up is neurodevelopmental follow-up. That means we look at the tone, we look at the angles, we look at his development. That's very, very important for when you follow up a low birth weight or a preterm baby, we follow him that for neurodevelopment. So what are the two problems which can occur with CNS? One is, of course, he said birth asphyxia. Second is long-term neuronal development, especially in a preterm baby. If you see specific, is what we call as periventricular leukomalacia, PVL. Okay, and it's many a times they ask you in a CP child. Suppose in a CP child, if you have, which is the area which is more affected? It is the periventricular area, PVL. It has fibers coming to your lower limbs. So what kind of CP they are going to have? They're going to have cerebral diplegia.
Yes.
So they're going to have cerebral diplegia, where you have seen that the lower limbs are more affected than the upper limbs. So this much you should know in the CNS. Okay, ears. Any problem with the ears, Prashanth?
On modified Ballard's code, we can see that they'll have less of development. The cartilage may not be developed adequately.
Yeah, cartilage is developed, but you know that because it's again the connections are not very well developed. So they are going to be more prone for hearing loss, isn't it? They're going to be more prone for hearing loss. So of course now it is universal hearing screen, but a preterm baby definitely we have to take care of the
Compulsory, they have
ears.
to go for bearer.
Very good. Ears. What about eyes?
They could, if they're resuscitated and oxygenation was given, then they have to be screened for retinopathy of prematurity.
Okay, so irrespective of whether oxygen is one of the risk factor.
Yes,
okay, so what happens is the vessels are also developing, isn't it? It starts from one side and then it goes to the end, either the ora serrata. It starts and it has to end and finish there. So suppose if any insult like our hypoxia, or if we are giving some blood, or if there is any insult, what's going to happen? There's going to be inflammatory markers, and the growth of these vessels will be stopped. Okay, so the growth of these vessels will be stopped, and after that what happens? Neovascularization occurs and more vessels are there. Once more vessels are there, it can just detach the retina. So there could be retinal detachment. So this condition is called as, in various grades, it's called as retinopathy of prematurity. Okay, so what in the eyes, what specific problem we are worried about is ROP, retinopathy of prematurity. That's why we screen them and follow up. You have to, one is neurodevelopmental outcome. The same answer question also I'm finishing what you do at follow up. They'll ask you what follow up you want to do. As he said, we could look at close neurodevelopmental follow up. Second is hearing screen. Then we do the eye screening. That means we look for ROP. What stage of ROP? As I said, first there will be a lack of blood supply. The new vessels will grow, and the new vessels, if they're growing more, and then you can have a chance that they can bleed, and they can also withdraw. They can also detach the retina. So you can have retinal detachment and blindness. And very important cause of blindness is ROP. So you detect early. You can do something called as laser, which you can block, or these neovascularization. You're going to just stop that. So you're going to take away that. So therefore, that is one of the treatments. So at least that much for your undergraduate level, if you know, I've made it little simple. So what problem in the eye you can have is ROP, retinopathy of prematurity, which you have to screen. If you're getting grades which are requires treatment, you're going to do treatment. Clear? And the treatment is the laser. Fine. So that's about the eyes. What specific abnormality of the RS?
Respiratory distress because of less of
surfactant, right?
Surfactant, yes.
Yeah. So you want to know that it's not only because of lack of surfactant, because of immature lungs itself.
Yes.
An immature lung, you have lack of surfactant. So always, whenever there is a lack of surfactant, you have a tendency to collapse. Correct? You always have the lungs to go at a tendency of collapse. Therefore, you have to support the baby right from birth. So we give something called as continuous positive airway pressure to keep the alveoli open. And as Prashanth said, give surfactant, and then probable ventilation for a child who's having severe respiratory distress. So RDS, respiratory distress syndrome, which again is a theory question, which you should know in little detail about what are the clinical features, What are the management? What is surfactant? You may get a question on that. What is the X-ray findings of RDS? What are the clinical features of RDS? That can be an exam question. Okay. Another important thing at the respiratory system, as I said, you can have, because of these, you have immature vessels, you have immature lung, so they can bleed fast. So that's called as pulmonary hemorrhage. One of the terminal events in a preterm baby is pulmonary hemorrhage. Okay. And because you're having an immature lung, immature tissues, and you're doing so many things, that means you're ventilating the child. Ventilation means it causes trauma, right? It causes trauma. It injures the lungs. So when you especially if it's a preterm, like an extreme preterm, less than 28 weeks, what can happen if there is a repeated injury? You open up the lungs, you close the lungs, you open up. So there's a lot of injury. Plus there is fibrosis. So you're going to end up in a condition which is going to be stiff and not much expanding lung. So we call it as chronic lung disease or bronchopulmonary dysplasia. So three things you have to remember at lung. One is RDS. Second one is pulmonary hemorrhage. Third is long-term consequence of a prolonged ventilation is BPD, bronchopulmonary dysplasia, chronic lung disease, CLD. Is it clear? So
Yes.
now what about cardiovascular system? What problems can you have in cardiovascular system?
There'll be more, not immediately, but after a few weeks, there can be more incidence of anemia and
Okay.
polycythemia immediately, which can lead to jaundice and
No, preterm and heart.
heart.
Preterm and heart, two problems.
Yes.
Preterm and heart, after birth, you expect as the pulmonary pressures reduce and the oxygenation occurs, the
Yes.
PDA usually closes, right?
Yes, sir.
So PDA is patent ductus arteriosus, right? So the ductus usually closes, whereas in prematurity, because you're doing so many things, that means you're ventilating the child, you're dealing with the pulmonary pressures. So what's going to happen? The PDA can open up. So
Yes.
PDA can open up. Once the PDA opens up, you know that it presents as failure in newborn. See, it presents as failure or increased oxygen requirement in the premature. So again, he may require ventilatory support, increased oxygen support, and he will manifest with CCF. So that is PDA. So what is the important cardiovascular manifestation in preterm is PDA, persistent or patent ductus arteriosus,
Yes.
PDA. And the second thing is, they are immature vascular substance, immature heart, less myocytes. So they're more prone for shock. They're more prone for shock. Clear that these are the two problems you can have in cardiovascular system. GIT, what problem can you happen in GIT?
They're again immature developed, so they can be more prone for feeding problems, followed by necrotizing enterocolitis.
Yeah, correct. So feed intolerance. So that's why it takes a long time for us. So here the associated questions you may have to, what do you mean by trophic feeds? What do you mean by minimal enteral nutrition? And then we should also look at what is feed intolerance and NEC. Necrotizing enterocolitis is a condition where you're going to have problems because of the hypoxia is the problem, and you have infection, and then you have lack of blood supply. So you have blood supply is less, immature gut is there, and then you have infection. Then you're going to have necrotizing enterocolitis. You have various stages that again can be a theory questions, but at least you should know the problems. When they say problems, you should say feed intolerance and NEC. Okay, fine. Next, what about renal?
Sir, they're again immaturely developed. So if in preterm, if they're more, if we are more resuscitated, we are given more fluids and
Okay. Yeah.
they
So
can
they're going to have, they cannot handle, yeah, they cannot handle too much fluid. They cannot handle too much electrolytes,
electrolytes.
correct? And they can have usually loss of electrolytes and bicarb also. So they're more prone for acidosis. They're more prone for acute kidney injury, correct? And they can have fluid and electrolyte abnormalities. This much you should know as well as renal is concerned. What about hematology, bone marrow? What problem can they have? As he already told, anemia,
Yes, sir.
correct?
So
And you know
first,
that
polycythemia, which
yeah,
can lead to
polycythemia,
jaundice.
as I told you, is more common in whom? Is more common in SGA
SG.
babies or IUGR babies because of in utero hypoxia and increased erythropoietin. There will be more polycythemia. So
Yes.
polycythemia means when the HB is more than 22 or the PCV is more than 65, we call it as polycythemia. Here they're more prone for anemia. That too, anemia, because you know that I said that most of the stores are minerals and vitamins are transferred during the third trimester.
No
So
accretion.
yeah, so therefore fetal accretion will not be there, and they are more prone. You have a lot of sampling being done, and you have so therefore normally as the erythropoietin stimulus is down, the HP, the nadir is going to happen, isn't it? The hemoglobin, which is very high at birth, then it keeps on coming down and reaches a particular nadir where your erythropoietin gets re-stimulated. Correct? When you don't have stores, then at that point you're going to have anemia, and that's called as anemia of prematurity.
Yes.
Okay, so you're going to have anemia of prematurity is one of the important. And second, in the newborn period, the more the preterm, more chances of anemia because you have sampling, less blood volume, so you can have anemia. Okay, right. So, and of course, most important as far as bone marrow is concerned, because they have hypercomplementemia, decreased chemotaxis, T cell immunity is depleted, they are more prone for infection. And they are again, you're giving more lines, you're doing so many procedures, so they are more prone for infection.
Yes, sir.
Clear? And long term, I told you this neurodevelopmental outcome is the most important as far as preterm is concerned. So that's how you're going to remember problems of preterm. So problems of preterm, you can remember system wise. It's very easy. So CNS, eye, ear, RS, CVS, abdomen, bone marrow. If you remember these problems and long term problems, you will be thorough with the answer of what are the complications you expect in preterm.
Sir,
Clear?
also they can have nutritional deficiencies and
Yeah. So the
rickets
long
of
term
the
problem is growth.
vitamin D deficiencies.
Growth problem. I'll be coming to that. So what is going to happen is, as he rightly pointed out, is that they can have, because all the accretion, fat accretion, as well as vitamins, minerals occurs in the third trimester. So therefore, you need to supplement these babies. So in feeding of low birth weight, two things are important. One is the method of feeding. That method of feeding you have already I've described earlier when the feeding history came, that below 28 weeks, IV fluids, 28 to 32 trophic feed plus OG, maybe OG feeding, and then you're going to 32 weeks, you're going to pallida feeds, and then DBF at 34 weeks. Plus, so what is going to happen is these babies, the growth is going to be exponential once they come out. So they need more, their requirements are more. So once the requirements are more, like for example, you read 150 kilocalories per kg per day. So if you want to do that, breast milk contains only 65 kilocalories, correct? So if you want to meet the growth, you need to give them something extra, correct? So that is the reason why you fortify the breast milk. So in a preterm baby, you fortify the breast milk. So that's what Prashanth was saying, that you need to fortify the express breast milk which you're going to give, because it does not meet the calories which is required for growth. Therefore, you're going to give something called as human milk fortifier, HMF sachet, or human milk fortifier. Now we have one packet which will be used which will mixed with around 25 ml of breast milk, and which will give you extra calories. Okay. The other is we use MCT oil, but of course MCT oil is not evidence based. Therefore, you can say HMF sachet. To make, how do you make it more calorie dense? If they ask you, then you're going to say you want to add some calories to that. You add high human milk fortifier. Clear? And second is, you should also know that you need, because the growth is so much and you have less stores, so you have to give multivitamins. So therefore, you give them either A to Z drops or Viziner drops. You would have seen what drops, and zinc. So zinc, the multivitamins are very important, along with iron. So these two things you have to remember. So you are going to give, if they're giving extra calcium, you give me extra calories by adding human milk fortifier. You're going to add the vitamins, and they're going to add calcium and phosphorus. So since HMF has calcium, so therefore we don't add the calcium because it becomes very hyperosmolar in a preterm. We tend to add as we go ahead. But in a low birth weight baby, and if you are going to supplement them with iron, multivitamins, and calcium. Now, how much of calcium do you want to give? And how calcium is around 140 milligrams per kg per day. Phosphorus around 60 to 90 mg per kg per day. Okay, so till the neonate is around 40 weeks gestation. So that's how you continue calcium. Usually, you give multivitamins till around 6 months. Iron you give up to 1 year. Vitamin D, 400 international units, you give up to 1 year. Of course, the recent recommendation is you give iron and vitamin D up to 2 years. Okay, so this much you should be knowing how to supplement and feed. And the other important question will be asked is how to follow them up. So follow up of a low birth weight infant is also important. One of the important problems which you will get at follow-up is not gaining enough weight. So what is the important cause of not gaining weight? One is temperature, mostly temperature, and whether they are feeding properly. So you're going to look at feeding, and as Prashant said, you may have to give direct breastfeed plus extra palatal feeding. And to the extra express breast milk, you may have to add extra calories to make it calorie dense and add adequate vitamins and minerals with iron. So that's so growth is one of the most important thing which you need to follow up. So is the baby growing? So you need to know what is the rate of growth. So if you look at normal babies, term babies, to about 2.5 kgs term babies, you know, he gains around 30 grams per day, right? 20 grams in the next 3 months, and then 15, like that, and then 12. So like that, here in preterm babies, it's based on the weight. Roughly, you can say somebody who's less than 1200 will be gaining only 5 to 10 grams per kg per day, 10 to 15 grams per kg per day in say 1200 to 1800. 1800 to 2500, they'll be gaining around 20 grams per kg per day. Whereas above 2.5 kg, it's around 30 grams per kg per day. Then what is the rate of head circumference growth? What is the rate of length? So head circumference will be around 0.7 centimeter per week in a preterm baby, whereas in a preterm baby, length is zero point 0.5 to 1 centimeter per week. So when they come to follow up, what you are going to do first is growth. Growth means you see based on the weight, how much the baby is growing, length, how much is growing, head circumference, how much is growing. So this is what you do in the clinic. Follow-up clinic, you're going to look for growth. Second is you're going to look for immunization. So as far as immunization of a low birth weight baby is concerned, you're going to say, even if he's a preterm, the immunization will be as per his chronological age. So the only difference in the follow-up of a preterm baby will be in development. In development, you have to do the corrected gestational age. So with development, you have to see, if you suppose if he's a 3 month old, if he's coming for your 3.5 months vaccine, but if he's born at 36 weeks, you correct 1 month gap. That is your corrected gestational age. So you give 1 month leavage for his development, right? So only development is as per corrected gestation age, whereas all others, your nutrition advice, immunization advice, everything will be as per chronological age. So immunization, all of you, he's already told that it is BCG, hepatitis B, OPV at birth, and remaining will be as per, but less than 1.5 kgs in a preterm baby. We don't, even if you're given hepatitis B, we don't count the hepatitis B. Hepatitis B is generally when he's above 1.5 kg. Okay, somebody who's below 1.5 kgs, we usually don't give hepatitis B because the uptake is quite low. So uptake is quite low. So that's because the muscle mass itself is not there. So you don't give them in a preterm baby. Otherwise, all others are as per chronological age. Okay, and they are more prone for certain, like especially the extreme preterms, they are more prone for recurrent respiratory tract illnesses. So some optional vaccines like flu vaccine, pneumococcal vaccine, you can give extra from whatever is mentioned in that. You can, they say if you want, if they ask you any specific vaccines you want to give for preterm babies, you say that you may have to give flu vaccine and you can give the pneumococcal vaccine for a preterm baby. Okay, so this, and as far as the other for one is growth, development, immunization, and the fourth thing you're going to do is eye screening. That's ROP screening, hearing screening. Of course, TSH is for everybody. No, so if you can't, TSH is also a part of thing. But as far as preterm and low birth weight follow-up is concerned, growth, development, immunization, and we look at ROP and neurodevelopment. So in the neurodevelopment, we look at measuring the angles, the tone measurement, and of course, developmental milestones. So this much, if you tell, I think that covers, these are the specific questions which will be asked. Again, to enumerate the questions, one is etiology of low birth weight. We discussed it, fetal causes, placental causes, maternal causes. Then how to classify these low birth weight babies. So I told you that they could be preterm or they could be small for gestational age. Small for gestational age, I said SGA, IUGR. IUGR, asymmetrical or symmetrical IUGR, differences between them, and what is the problems of SGA. First I mentioned problems of SGA, and then I told you problems of prematurity. And what are the problems you can get? how to follow up a preterm baby or a low birth weight baby, how to feed a low birth weight baby or a preterm baby. These were the important questions as far as low birth weight baby is concerned. Apart from that, because if you're getting newborn as a case, you will be asked some questions on jaundice. Of course, preterm babies are more prone for jaundice. In GIT, one more problem is they're more prone for jaundice because of immature liver, immature enzymes. Therefore, they can't handle the load, so they can be having more jaundice, right? So you enumerate the problems, and you specific questions on jaundice can be asked. You may be asked specific questions on what are the normal newborn findings, correct? And specific questions on anthropometry, specific questions on normal newborn reflexes. Since it was discussed in the last class, I've not done anything about newborn reflexes. At least 5 reflexes you should be knowing. One is Morose reflex, grasp, then you should know about plantar palmar reflex and ATNR. These 5 reflexes you should be knowing when they appear, when they disappear, and if they persist, that is the problem. So this much, I think, if you know, low birth weight infant is, this is what are the expected questions which will be asked. Yeah, Prashant?
Yes, sir.
Yeah. So if any doubts are there, specific doubts, then otherwise, I think we have covered most of this in the discussion.
Sir, someone has asked if you can repeat about the Fenton's charts.
About the Fenton's chart.
Yes.
Yeah. Okay. So in Fenton's chart, what we are actually looking at is when we want to classify these low birth weight babies, I said they could be SGA, correct? You want to know as far as the population is concerned. When you compare it, when you arrange all these small for gestation babies, how to classify them? If you arrange them in ascending order, if those who are falling below the 10th centile for that gestation, like for example, here we're seeing that it is 35 weeks, you have plotted him on, it's almost coming on the 10th centile, correct? So suppose if it comes below the 10th centile, you call them as small for that gestational age, or small for SFD, small for that date, correct? If they are between that 10th centile and 90th centile, you call them as appropriate for gestational age. If they are above the 90th centile, you call them as large for gestational age. Okay. The other point which I mentioned in the Fenton's chart is, one is you need to monitor them during growth, correct? During the follow-up, you're going to monitor and you see how much growth is he going on the centiles or is coming down the centiles. The other point, clue for the chart as far as low birth weight is concerned is, suppose I have a problem and you have a doubt about the ponderal index. So then you also have, in a symmetrical SGA, usually all the parameters, that means the weight, the head circumference, and the length, all of them will be in the lower centile. That means it will be below the 10th centile. Whereas if it's an asymmetrical SGA, only the weight will be less, whereas the other head circumference and the length usually will be spared. They're usually long and thin babies. Only the weight will be less, whereas the other parameters will be normal. Is that okay?
Yes, sir.
Yeah. Fine. Any other specific question with relation to?
There are no other doubts in the chat, sir.
Any doubts, guys? Please feel free to ask.
Somebody was asking whether we need to measure blood pressure. I saw that question coming up. So usually we don't expect you to measure the blood pressure, but at least you tell them it is not through your blood BP cuff. It is through the monitor. So you're going to use it in a non-invasive manner. You're going to use blood pressure which is through the monitors only. It is not through the you're not going to manually measure it. You need not measure the blood pressure, but you need to know the normal. So normal is gestational age plus 5. For example, if you say is a 40 weeker, 45 is normal blood pressure for that newborn. At least that, and below 30 for any gestation age is hypotension. At least you need to know that much. I think they will not ask you to measure you're not expected to measure the blood pressure.
So that's all, sir. I think so. The doubts.
Okay.
Prashanth, any doubt do you have?
No, sir, that's it, sir. I'm really sorry for all the glitches.
Hey, no. That's totally okay. Not a problem. Can understand. So would like to thank you, sir, Jagdish sir. Class was like extremely comprehensive, covered all the aspects. So thank you for taking your time, sir.
Yeah, no problem. Always a pleasure to be with. So in case they have any things they want, anything, actually I thought I could project my slides on it, but I thought it will become like a theory class, so that's why I didn't project the
Sir.
slides.
Yeah,
So
yeah,
probably
sir.
if they want something extra like last time, we can just send some material for reading.
Yes, sir. Sure, sir. That I'll share it in our
Yeah.
group, sir. In
Fine.
that case, yes, sir. Thank you so much, sir. And Prashanth, a really very good presentation. You too had your internals and all. Still, you managed to come up and present. Thank you for volunteering, Prashanth.
Thank you, sir.
Yeah, and thank you guys for participating in the session. So hope this session was useful for all of you. So we can end, I think so. Thank you and good night.